PCI, a case-based discussion. Dr. Tanveer Ahmad.
Thank you. So the previous lectures has actually made my case very easy and simple. So I'm Dr. Tanveer from United Hospital. So it's a retrograde PCI step by step some discussions. So I have nothing to disclose in relation to this presentation. So it's about a 65-year-old lady. She's hypertensive, non-diabetic, having bronchial asthma, presented with class 3 angina, ECG and echo were normal. So we did the angio. We can see there was no significant lesion in the LED. Significant lesion in OM was seen and retrograde filling to the RCA. So we can see the RC was diffusely diseased with a bridging CTO in the distal part. We can see it's about 2 centimeter, getting both antegrade and retrograde filling. So JCTO score of about 2. So the patient was actually fragile, elderly woman, so we kept her on medical management initially. But even after being on medical management for 2 months, the symptoms were gradually worsening and she came back to us for PTCA. So what now? We had a bad experience with the radials during the angio. It was quite narrow and tortuous. So we decided to address the CTO through the femoral approach. So considering the JCTO score, the first plan was for antegrade, and then if it failed, we'll go for the retrograde approach. So we took dual catheter to see the filling from both the sides. We can see some bridging. There could be some microchannels, but we are not sure of it. So we tried with the antegrade approach with the filter XT wire to see if there was any microchannels, so the filter XT wire could track through the channels. But unfortunately it failed. So we escalated using Miracle 3 and Gaia Next 2, but those also failed. What happened is the Gaia wire went into the subintimal space. We can see from the retrograde dye injection. So what now? We tried the antegrade approach, it failed, it was not successful, so we switched to the retrograde approach. We already had a 7 French XB in the left system, so we used that catheter for the retrograde approach. So we first selected the septal branch, which is giving a good collateral to the RCA. We tried to enter it in the initial part with the BMW and the microcatheter. And then as Aftab sir showed in his presentation, before putting in any dye, we had to make sure we had a free flow of the blood through the microcatheter in the septal, because if there's no flow and we inject, we are going to perforate the vessels. So once we got the flow, we injected a small dye. We saw the track of the collateral. We used a SUO3 wire. It's nothing that we will be using with force. It's just tracking it. It will be surfing through the collaterals, as we can see here. We advanced the caravel gently, and the SUO3 wire, with gentle surfing, it went into the PDA. It crossed into the PDA without much difficulty. So next, after we crossed the SUO3 wire, we had to cross the caravel, but the caravel was giving some trouble crossing to the collateral. We know the caravel is a good microcatheter, but it's a bit hard end. So what next? What are the options? Should we change the microcatheter to some softer end, use the anchor technique, or dilate the collateral using a 1.2 balloon so that the caravel can cross through? So we changed to a softer end, ZZI. It's a Asahi microcatheter, and then it crossed the collaterals quite easily. It crossed into the PDA, as we can see. And then next, we checked through the microcatheter by giving a retrograde whether we are in the true track. And as I've said previously, we have to make sure that we have a free flow of blood before we inject something. So then we tried to deal the lesion with Miracle New 3 wire. And as there was an antegrade wire marker, we used a reverse cut technique, and then the wire successfully crossed the lesion. Then we anchored the retrograde wire into the antegrade catheter, and then we pushed the microcatheter forward through the lesion across the RCA. And then we did the externalization using the RG3 wire. Bed preparation was done over the RG3 wire using 1.5 and 2.5 balloon. And now, where and how to stent? That is an important question because we have done the reverse cut, we have created a dissection, re-entry. There is always a chance we have hematoma, we have dissection. So we don't want to put in the antegrade dye which will increase the dissection or cause vessel closure. So what we did is we used an IVUS to see the landing zone. So we took an IVUS caused the lesion easily. And then it showed the landing zone was at the bifurcation, just before the bifurcation. So integrately, we took another Fielder XTR wire to have an anatomical landmark where we are going to place the distal stent. So we placed the stent over the RG3 wire, 2.25 and 2.5 in the distal and the mid segment of the RCA. And then next we put in 2.75 stent in the proximal part. As the distal part was secured, so now it's quite safe that we can inject the dye integrately and see the landing zones. Post dilation was done satisfactorily. So after stent deployment, we again repeated, checked for the angio if there was any dissection or perforation. Then we pushed back the microcatheter forward. The reason being is the RG3 catheter is quite a robust or a tough wire. So sometimes if we pull it hard, it has a cutting effect. So in order to avoid that, we put in the microcatheter within the stent, and then we brought in the RG3 wire back. And then we pulled the microcatheter. After we pulled the microcatheter back, we again did an angio check shot of the collaterals, whether there was any perforation or not. After that, we repeated an IVUS of the RCA, where you can see the stent deployment was quite satisfactory with no significant indentation. The MLA were quite good. And then finally, we did the OM3 with OM lesion, which was quite easy. So we successfully managed to address this CTO by the retrograde approach without any major complication. So my take-home message from this case was, while dealing with CTO, we must have all the proper hardware and with a proper plan. We must have a backup plan in case our initial plan fails. As in this case, our initial plan was antegrade, so we have to switch to retrograde. So retrograde PCI is a much delicate thing rather than using force. As sometimes in the initial parts of my career, I thought retrograde will be much more harder with much more force, but it's much more delicate. And as in my previous lectures we have heard, we must be aware not to make complication. And then imaging in such cases is always helpful. It helps in bringing precision to the procedure. Finally, I would like to acknowledge my mentor, Kaisa sir, who has been my mentor and guru in the intervention field. Thank you, sir.
Thank you very much. This is the right student of the right teacher. It's an excellent demonstration.
Now, exercise session, quiz competition. Please download your, I think everybody have apps here. Open your apps. Open. Hello iPad apps. Please take 10 minutes, 10 second time. Everyone have the apps. Go. Now already open. they have don't try. They are already there. If not, they are not qualified. Okay, Nasim, please start. Start now. Start now. Start. Can we display the question here? This number one question. There is. You see? I said, wait. This is the question. Number two, second one. Number three. Last number four. And number four. These are not number three, number four. Which wire is not suitable for causing microchannel? I think not so tough question. Any other question? I think 4 is okay. Okay, good. 10. Okay, stop. Stop. Now give the results. We were waiting for results. I'm requesting Dr. Aftab Khan and Kaisar Khan, please discuss the questions. Answer তোমার কাছে আছে না সবগুলো? Answer কার কাছে তোমার কাছে?
মতিউর ভাই।
মতিউর? ওই answer দাও কাইসে বলি? Answer. Okay, MD Shahadat Hussain, Mohammad MD Shahadat Hussain take number 3 points. Saiful Islam Tipu Chaudhary 3 points. Afroz Ahmed 3 points. There's the first, second, third. Dr. Sakubi third, but the first is finger first. So first Shahadat Hussain, who is Shahadat Hussain? Yeah, good. Second Dr. Saiful Islam Tipu Chaudhary, second, and Afroz Ahmed third. Okay, I'm requesting. Please come here. Aftab Khan, please come here.
Second, Saiful Islam Tupu. Number third, Afroz Ahmed. Sir, united, sir. Yes, sir.